talk about reliability of tests. Reliability of a test is synonymous with repeatability. Repeatability means if I do the test for the first time and I get a certain result, if I repeat the test, will I get the same result? That is repeatability. Reliability. We need tests which, when you conduct them, you get the same result consistently. So a test can be accurate. Accuracy is the same as validity, but it may not be repeatable. You repeat the results and you get different findings. For instance, if it is a weighing scale, we want a weighing scale to measure all objects with the same weight, and it returns the same weight. If they have the same weight, it should return the same weight. If I put the first packet with 1 kilo, it should return 1 kilo. If I put the second packet consistently, it should be reliable. If I put, subsequently, I put a kilo and it returns 750 milligrams, then it will no longer be reliable. I would illustrate this with a jet engine. A jet engine propels a very huge aircraft, sucks in the air, compresses it, and propels the aircraft all through rotating for 9 straight hours that the aircraft takes, say, from Entebbe to Amsterdam. And then the following day, the aircraft, you don't know, it may be assigned to go to Brazil, and the 2 engines will reliably do the same thing for another 15 hours, and the following day it may go to China. So reliability, it means you return the same result all through. So reliability. Now, what are the factors that affect reliability? One of the key things in reliability is precision. Precision. Precision means how close or consistent are the repeated measurements. So we are interested in the precision. So those are part of the components of reliability. While in accuracy, how correct are the measurements? So accuracy is another term for validity. But precision is how close are the measurements. We can illustrate this using a darts game. We have this player here who is very consistent in throwing the dart here, but it is away from the bull's eye. So they are quite reliable, but their play is not valid because we are targeting the bull's eye. They are constantly, so they are reliable in doing the wrong thing, but they are consistent. Now, here we have this category. This group has some valid findings. They have some valid findings. So they have some validity. They hit the center here, but they are not very reliable. They keep spreading some of the play. This group is neither reliable nor valid. Everything is not near the center, and it is spread out. This group is both valid and reliable. Now, what are some of the factors that affect the repeatability of a measurement? It could be the person whom you are measuring. The person whom you are measuring can vary internally, physiologically. For instance, the temperature, their basal temperature can change during the day or over certain seasons. They may feel warmer during certain seasons because of the environment and that. Their hormones may keep changing. Their hormonal cycles may keep changing, therefore returning different results. The length could change. Like we know during the night, we are longer than during the day because during the day we are standing and our skeleton tends to collapse on itself. So we measure the height early in the morning, it may be different from the height at midday. But also the person who is doing the observation, what is their diagnostic acumen? It could be the change in the measurement instrument. It loses calibration, or it loses some of its functionality. But it could be also a change in the case definition. If you're doing a clinical diagnosis, the case definition may change. So this can affect the consistency of the measurements. Now, we shall talk about one way of assessing reliability of measurements. Here, we get 2 observers. One observer does the measurements. Let's say they read the x-rays, and they classify those that are positive, say for TB, and those that are negative. And then you get a second observer. That observer also classifies those that are positive and negative. So we have situations in which both observers agree that these are positive, this is TB. Then situations in which both observers agree that this is negative, so that one. Then we have these situations where they don't agree. One says it's positive, the other says it's negative. One says it's negative, the other says it is positive. So those ones. Now, this is different from sensitivity and specificity because we are not saying this is the gold standard. No, we are just getting two different observers, maybe lab technicians, and they take the measurement. So we compute the proportion of readings for which they agree. That is A plus D over the total number of readings, and we compute a percentage. That is called percentage agreement. Now, how do we deal with reliability with multi-level variables? Here we've just said two observers, one positive, another one negative. What if these are several? Let's say mild, moderate, severe, and mild, moderate, severe. That requires some more advanced statistical procedures that are outside the scope of this session, like scales, which measure attributes in a range. Now, finally, let's reflect on the application of some of these principles that we've outlined. HIV. The primary care screening test for HIV in Uganda is called Determine. 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 Now, Determine is a very simple strip where you prick someone, put the drop of blood, put something, a drop of a fluid that is called a buffer, and then this substance starts moving in this direction using what we call, it's like, this is like a filter paper. So it moves using diffusion through this filter paper. And if someone is positive, their blood reacts with a certain substance to form a dark band in the strip. And there's also a control band which turns dark whether you are positive or not. So that one shows that the test is functioning well. If it doesn't turn dark, so this is the control. If it doesn't turn dark, it means the test is probably spoiled. But the first one is the test. If it turns dark, it means it is positive. But if it remains like that and the rest goes through and you only get one band, it means that the test is negative. Now, this test is very simple to apply. Even the average person can apply it in their household as long as you are able to prick yourself, get a drop of blood, and you also have the buffer. So this is what we want in public health. We want everybody to be screened in the whole of Uganda. We want everybody, every health worker in a health center too, even community volunteers, to be able to do this test. Anybody can, when they are with very short training, they can be able to do it. So that's what we desire. So it's the first line screening test. However, this test has a sensitivity of 99.99996 if you check in the product insert. So it's almost equal to 100. But its specificity, the specificity of this test is 99.5%. So it's 99. Now, this one looks small, but when it comes to national level screening program, it's quite substantial. So you imagine that you screened you get 1,000 people with a disease, 1,000 with a disease who actually have HIV. 1,000 people, if you got 1,000 people who are proven to have HIV using the gold standard, which is DNA, PCR, or electron microscopy, or what, this test has a sensitivity of 99.99, which is almost 100. So you'll get the true positives will be 1,000, but the false negatives will be 0 because the sensitivity is almost 100%. But if you got 1,000 people who are negative and you applied this test with a specificity of 99.5, out of every 1,000 people, it will identify who are negative. It will identify 995 as negative and will misclassify 5 as positive. So there will be false positives. So if you just get positive people and you tell them their results, out of every 1,000 negative people, there will be 5 false positives. Now, when you translate it, let's say the population of Uganda is about 30. Let's say a country has a certain country has a population of 40 million people, and let's say its HIV prevalence, the actual prevalence determined by the gold standard, is 10%. So 10% of 40 million is 4 million. That means the people who are actually negative are 36,000,000. It means that these are actually negative. When you apply this test, for every 1,000, there will be 5 false positives. How many thousands are here? There are 36,000 times 5. This is approximately 200,000 people misclassified as being positive when actually they are negative. So that's the challenge with this test. So in Uganda, all people who turn out positive with this determine, which is also called the rapid capillars test, they are subjected to a test with a higher specificity. We said to increase specificity, you do simultaneous testing, but you also, here they combine simultaneous testing and the test with a higher specificity, which is, so we start with the determine, then all positives, they are subjected to a second test which is called start pack, which is the second line screening test. Now, that test increases specificity, so it reduces the false positives to nearly 0. But the problem is some of the true positives now turn negative. So that is why in Uganda we apply the third test, which is the tiebreaker test, and it is called Unigold. So all those who are positive at the beginning, then they are negative in the second one, they are called indeterminate. So they undergo what we call a tiebreaker test. So that's the rationale for building a screening program for HIV/AIDS. Now, as I conclude, I would like us to think about screening for STDs. I talked about the syndromic management. Then let's think about screening for cervical cancer. What are the different tests that are available and which of these are applicable at primary healthcare level? Visual inspection of the cervix using after applying acetic acid, using a microscope that is inserted into the reproductive tract, colposcopy, or taking a swab of the cervix and you do a pap smear, or taking a bit of the tissue from the cervix, which is a cone biopsy. You are moving towards the gold standard. Think about malaria. In the past, malaria was diagnosed based on having fever, but with the strong rollback malaria programs, fever is no longer sufficient as a diagnostic criterion for malaria. We need more valid tests. So they insist that we need to do either a rapid diagnostic test, the RDTs are now available, or microscopy, which is the gold standard, but it is very highly technical. So we need to do the RDTs. Think about diabetes. The 2 primary healthcare screening tests available is fasting plasma glucose and hemoglobin A1C. But the 2 still have challenges in terms of their sensitivity and specificity, especially in application in our low prevalence environment here. So in summary, these are the key principles of validity and reliability of screening tests. Thanks for listening.